My name is Lovro Lamont. I'm a pediatric rheumatologist in Sestre Milosrdnice University Hospital Center and a postdoctoral researcher at University of Zagreb School of Medicine in Zagreb, Croatia. I'll present two cases of difficult JIA patients, much similar but also slightly different from the ones I'm sure you all have in your practice. I have no conflict of interest either in virtual or real world. As a short introduction, I would like to mention that the last 2 decades brought many new advances into pediatric rheumatology practice. We have new biomarkers, new treatment options, new guidelines, as well as new disease indices. Nevertheless, some old challenges remains. There is still a problem of a wide differential diagnosis and various classification criteria. Then, how to select the most appropriate treatment option, how to know when to de-escalate or stop treatment, and how to deal with unresponsive patients. The problem is also the definition of remission, since today we can distinguish remission on different levels. Finally, regardless of those tremendous efforts being made, there is still more than 85% of patients with RF negative and 100% of patients with RF positive polyarticular disease who cannot achieve remission of medications within 5 years. First case I will present will be about a 16-year-old girl with refractory extended oligoarticular disease and Léri-Weill syndrome. She first presented at the age of 3 with painful swelling and limited range of motion of both knees, along with severe morning stiffness. She had no prior trauma or infection and no other predisposing factors related to the disease. Besides elevated TSR and CRP, her initial laboratory findings were uninformative, with negative anti-nuclear antibodies and reuma factor, and no presence of B27 antigen. She was initially treated with NSAIDs, intra-articular steroids, and methotrexate, but symptoms unfortunately progressed, and she even developed active uveitis. Naturally, this necessitated treatment. Since this was back in 2008, there was not as many options as today, and since she had an active uveitis, infliximab was first introduced. After the good initial response and remission that lasted for a bit more than 2 years, she had a flare, so the treatment had to be changed. At that time, adalimumab, another TNF inhibitor, became available, and due to the uveitis, this was a therapy of choice. Nevertheless, the initial remission didn't last very long, and in a year and a half, she was switched to tocilizumab. Again, she had an initial remission lasting roughly 1.5 years, and afterwards she was switched to etanercept, regrettably, once again without lasting remission. During that whole time, other diagnoses besides JIA were considered. First of all, inherited metabolic diseases, then immunodeficiency-associated arthritis, then SLE, and even malignancy. Nevertheless, laboratory findings were negative for other diagnoses and were mostly in line with the diagnosis of JIA, with increased concentrations of inflammatory markers and pro-inflammatory cytokines. Despite the treatment, she had many episodes of flares with up to 30 active joints, while outside of these episodes, limited range of motion in many joints persisted. Moreover, she became steroid dependent. Well, all of us know that steroid administration is associated with many adverse events and how important it is to use steroids in an optimal way, balancing the risks and benefits. Specifically, our patient had many of the symptoms of prolonged use, most prominently growth retardation and low bone density, so she received adjuvant therapy with ibandronic acid. Moreover, many unconventional treatment options, mostly based on the data from adult patients treated in prebiologic sera, were tried in order to win the steroids. Unfortunately, none of them led to the sustained remission. Finally, in 2018, a JAK inhibitor tofacitinib was introduced. This led to the remission and ultimately to winning and discontinuation of steroids. Moreover, since tofacitinib is orally administered in form of pills, it had an additional benefit for a young lady that received a lot of injections during her life. Soon after musculoskeletal symptoms subsided, medullary deformity was noted on the X-ray. This, along with a short stature, raised the suspicion for the Léri-Weill syndrome, which was confirmed after the genetic testing. Although it was the first time that a syndrome was found in a patient with JIA, the severity of musculoskeletal symptoms in our patient could not be explained by this syndrome. So finally, today, our patient has structural damage caused by disease activity itself, but also some consequences of prolonged and various treatment options that were in use. The second case I'm going to present is also about a 16-year-old girl, but this time with long-lasting polyarticular disease and subsequent development of sacroiliitis and IBD. The disease initially presented at age 1 with painful swelling and limited range of motion of right wrist, right knee, both ankles, and right hip. She also didn't have prior trauma or infection and no other predisposing factors related to the disease. Her inflammatory markers were increased as well, immunological screen was negative, but she was positive for B27 antigen. Again, she was treated with course of NSAIDs, then intraarticular steroids and methotrexate, and despite she had further progression of symptoms. Therefore, treatment with biologics was started. Like in the first case, she was treated with 4 different biologics, with initial good response, but with no sustained remission, except for infliximab, which was discontinued due to the anaphylactic reaction. Moreover, like in the first case, we didn't have the possibility to test for the anti-drug antibodies. Finally, the treatment with etanercept was reintroduced. Once again, a prolonged remission was achieved, but several attempts to decrease the intervals and discontinue the treatment led to flare and reintroduction of the treatment. Interestingly, throughout the course of the disease, the phenotype in our patient evolved. First, at the age of 1, the dominant finding was the arthritis of the large joints. Then, at the age of 3, the arthritis of small joints of hands became noticeable as well. Then, at the age of 5, she started to complain of back pain, and subsequently mild sacroiliitis was confirmed by imaging. At the age of 10, she started to complain of abdominal pain and loose stool. Moreover, her antinuclear antibodies went from negative to positive at the age of 15, while her fecal calprotectin levels increased to almost 1,500. Finally, at the age of 16, ileocolonoscopy was performed with a findings suggestive of inflammatory bowel disease. This evolving phenotype raised some questions regarding the disease classification in our patient, like should it be classified as a polyarticular disease or enthesitis-related arthritis. Interestingly, this issue remains both with old and new Euler criteria, and therefore we do not have a definite answer. At last, as in the first case, there are ongoing consequences of the disease itself, but also of the several treatment modalities used to tackle the disease activity. Interestingly, for this particular case, there are many studies of a clinical association between spondyloarthritis and IBD, but also many reports of IBD associated with prolonged use of etanercept. To conclude, every clinician involved in the care of children with JIA and eventually sees one that does not follow the treatment guidelines. As described in our 2 cases, at that point, it is important to modify treatment options by either changing the biological DMARDs, adding the steroids, or initiating some new treatment option, like tofacitinib, for example. Sometimes, different disease subtypes, alternative or additional diagnosis should be considered as well. Well, whatever the case is, we should emphasize to patients, their families, and their surroundings that juvenile idiopathic arthritis is a long-lasting commitment of everyone involved. Therefore, it is important to make everyone aware that children and young people get rheumatic diseases too, so please support our global initiative that spreads this word. In the end, I would like to thank my team for their continuous support and to all of you for your attention.
Hi, I'm Tim Buchelman, and the title of my presentation is Clinical Trials, what they tell us and what they don't. What do clinical trials tell us about refractory JIA, since that's the topic of this session? Well, they tell us that many biologic agents are more efficacious than placebo for the treatment of poly-JIA and systemic JIA. And these same biologics have an acceptable short-term safety profile. TNF inhibitors are probably more efficacious when combined with methotrexate. And they tell us that biologics can be efficacious in patients with prior biologic failure, but that the likelihood of response is lower. What clinical trials don't tell us about refractory JIA is basically everything else. There's no published active comparator, that is, head-to-head clinical trials of agents for the treatment of refractory JIA. And few inferences can be made by comparing placebo-controlled clinical trials because of the small number and differing proportions of refractory JIA patients in those clinical trials. So that concludes my talk. And just kidding. What can we do about this situation? Well, one thing we can do is to implement different clinical trial study designs. Dating back to the very first clinical trial for a biologic for the treatment of JIA, a novel and innovative study design was used, the randomized placebo-controlled withdrawal study. And the primary advantage of this study design was that it limited placebo exposure. That was highly important at the time. However, the use of placebo in JIA studies is becoming increasingly less ethical and less feasible. It seems unlikely that placebo-controlled studies are going to give us important answers about the study of refractory JIA. So instead, we should likely replace the placebo arm with an active comparator, such as a biologic or a targeted small molecule. The advantage of this approach is obvious. The efficacy measures would be highly clinically relevant, and enrollment in a study such as this would be appealing to participants and clinicians. The disadvantage is that they require large sample sizes to detect differences in efficacy or to confirm no difference. And why is that? Well, if we think about placebo-controlled clinical trials, the null hypothesis is that there is no difference between drug A and placebo. A sample size calculation is undertaken to make sure that we can detect a clinically significant difference. Then, if the study shows a p-value of greater than 0.05, we conclude that we cannot reject the null hypothesis, or that the study failed to detect a difference. Strictly speaking, it's not correct to accept the null hypothesis that there is no difference. But when it comes to placebo, we're not really interested in no difference, and it's a minor point. However, when it comes to the active comparator clinical trial, we may well care if there is no difference between drug A and the comparator drug B. However, it's extremely unlikely that two treatments have precisely the same identical effects. So if we were to use an infinite sample size and continue enrolling patients, we could always show some small difference between drugs. So when do we know when to stop? One way to approach this situation is with a non-inferiority margin. And this signifies when drug A is close enough to drug B. And the next few slides illustrate this concept. So here we see a figure where we're going to plot results of a clinical trial, drug A versus drug B. And down the middle of the horizontal axis here is a 0 point where there's no difference between them. So drug studies plotted to the right is where drug A is better. Studies plotted to the left is where drug B was better. Before we plot the results, we want to figure out where the non-inferiority margin is. So this is again where the treatment effect of drug A is not meaningfully worse than drug B. There's different ways to determine where this margin should lie. It should be based on clinical information or statistical information, and it should always be determined before the start of the study. In this case here, we'll just arbitrarily pick a value of -5. Let's say that we're measuring effectiveness on a 100-point scale, and we're going to say that as long as they're within 5 points of each other, that's close enough. So if we plot the result of the first trial, we see that in this study, drug A was a little bit better. It was 1 point better on average. And the lower bound of the 95% confidence interval goes down to -3. So it doesn't include this non-inferiority margin of -5. And we conclude that drug A is in fact non-inferior to drug B. Another example here again shows that the lower limit of the 95% confidence interval does not include this -5. And we can say that drug A is non-inferior to drug B, even though the point estimate of this clinical trial showed that drug B may be a little bit better. Next example shows a trial where drug A was 3 points worse than drug B, and the lower bound of the 95% confidence interval does extend beyond -5, down to -7. So the non-inferiority margin is included within the 95% confidence interval. The conclusion here is that non-inferiority was not demonstrated for drug A. We wouldn't say that drug A is inferior to drug B, because as you can see, the upper bound of the 95% confidence interval goes up to +1, and the possibility that drug A may be better. Another possibility is that drug A could be shown to be better than drug B. Here the point estimate was 5 points higher for drug A, and the lower bound of the 95% confidence interval goes down to +1. So the entirety of the 95% confidence interval shows that drug A is better. In this case, we say that drug A is superior to drug B. That's one of the nice things about these non-inferiority studies is that even though they're designed to show non-inferiority, if they happen to show superiority, that can be stated and there's no statistical limitation on being able to say that. Studies such as this have been published in rheumatoid arthritis. Here's the first one that was published, and they showed that abatacept was non-inferior to adalimumab at 1 year. As far as we're concerned, one of the challenges here is that the sample size was 646 patients. So what can we do? Well, we can replace the placebo arm with an active comparator, but it seems clear that we're going to need larger sample sizes for our studies. One way we can accomplish that is by reducing the burden of participation. And one way to accomplish that is by introducing pragmatic clinical trials. The idea here is to lower the burden for participation and to replicate real-world situations as opposed to the highly rigid situations of clinical trials. So we're going to increase the acceptability of the protocol to both the participants and the investigators. We're really looking for real-world effectiveness here. We're going to have broad subject inclusion criteria so more patients can be included. We're going to have flexible interventions that are similar to regular clinical care as opposed to a highly protocolized situation. There's usually not the use of a placebo arm. Oftentimes usual care itself is one of the arms of the trial. We have reduced intensity of follow-up, so again within the context of regular clinical care as opposed to dedicated study visits. These studies work best when the primary outcome is objective, easy to measure, and clinically meaningful. This is a little more challenging in our field than some others. And lastly, the analysis is usually a simple intention to treat analysis where patients are just assessed as they were randomized within the trial. There's been at least one pragmatic clinical trial published in RA. In this study, 300 patients with the failure of a first TNF inhibitor were randomized to receive either a second TNF inhibitor or their rheumatologist's choice of a non-TNF inhibitor biologic. And they looked at 6-month outcomes and concluded that the non-TNF inhibitor biologics were superior to the second TNF inhibitor. In addition to pragmatic clinical trials, we may also consider changing our analytic approaches. So I'm not going to go into detail about Bayesian methods, but the point I'd like to make is that even without knowing it, most of us interpret the world from a Bayesian viewpoint. The frequentist, or classical, or p-value approach is to assess the probability of the observed data given the null hypothesis. The Bayesian approach, on the other hand, is to assess the probability of the hypothesis given the observed data. So the frequentist asks, what is the probability that the results observed, or more extreme results, would have occurred by chance alone if the study drug is less than 80% effective? Compared to the Bayesian question, which is, what is the probability that the study drug is effective at least 80% of the time, given the observed data? So in addition to the more straightforward questions that can be answered, the Bayesian approach can also incorporate prior knowledge of the efficacy of study drugs, which we almost always have from studies of rheumatoid arthritis or other types of data. So this information can be incorporated using prior probabilities, greatly increasing the efficiency of the analysis using the Bayesian approach. Of course, the frequentist approach ignores any prior knowledge and you sort of start from scratch in your analysis. Another limitation of the frequentist approach is worry about multiple comparisons and how that may affect the interpretation of the p-value. This is not the case in the Bayesian approach, and interim analyses or multiple analyses are not a concern. This can lend itself to developing clinical trials that are so-called adaptive clinical trials, where by design, the conduct of the trial can change during the trial based on the accumulating evidence. One way this can be done is by randomizing a greater proportion of newly enrolled patients to an arm that appears to be more effective in the study. So during the study, you do an interim analysis and it looks like drug A is the most effective. Moving forward, you can randomize more patients to that treatment arm, and this can increase the precision around that estimate to prove that it is actually more effective, as well as enrolling more patients into the most effective treatment arm before the study is even over. Other ways that adaptive clinical trials can be used is to discontinue studies early, either because the study drug is clearly superior or clearly futile. And another way that adaptive clinical trials can be performed is rather than stopping the study early, you can actually extend the study if during an interim analysis it appears that a larger sample size may give a more definitive answer. Rather than stopping the study to figure this out, you can actually just extend the life of the study and enroll more patients. So in addition to considering Bayesian methods and how they may allow us to use adaptive designs in our clinical trials, another thing that we need to consider is trying to reduce the heterogeneity among our study participants. When patients are dissimilar, differential treatment effects, if they exist, they can be diluted, and this can require very large sample sizes to observe. So, for example, if for most patients drug A and drug B work about the same and it doesn't much matter, that's okay. But if there's a small population of patients for whom drug A is clearly superior to drug B, it will take a very large sample size to make sure enough of those patients have been enrolled in the study in order to detect that small difference. The trouble for us is that JIA is a very heterogeneous condition, especially RF-negative polyarthritis, which is the majority of polyarthritis patients in clinical trials. So patients with RF-negative polyarthritis, some of them have rheumatoid factor negative rheumatoid arthritis. Some of them have spondyloarthritis that has not been recognized. Some of them have probably have a unique childhood condition that is the polyarthritis form of oligoarthritis, and there's other possibilities as well. But I think we can all agree this is a very heterogeneous group of patients, and that may make it more difficult to identify superior therapies. In addition to the problems with our JIA categorization, of course, there's individual genetic and immune system factors that we don't understand that determine response to treatment. So my point is that in the conduct of these clinical trials, we need to be sure to also be conducting translational studies that will help us identify biomarkers that can predict treatment response. This is precision medicine or stratified medicine. So what can we do to increase the knowledge about the treatment of refractory JIA? Well, we need to replace the placebo arm with active comparators. We need to consider ways to increase the efficiency and acceptability of our clinical trials using pragmatic designs and adaptive designs. We need to consider using alternate methodologies that are more efficient and more directly answer the questions we're interested in. And lastly, we need to reduce heterogeneity as best we can by continuing to strive to find biomarkers that can predict treatment responses. Thank you.
Good evening to all of you. I was given the title How I Manage Refractory JIA. I will have a look to the future as well, so I kind of changed the title to include this. Here are my disclosures. So if we are going to talk about refractory JIA, we need a definition of refractory JIA. I think that the best way to get a definition is actually to start from the target that the Treating to Target Task Force identified a couple of years ago. The primary target for treatment is clinical remission, which is defined as it's written here. Minimal or even low disease activity may be an alternative target. So based on this, I think that operational definition of refractory disease are the following. Polyarticular JIA, failure to achieve clinical inactive disease of glucocorticoids at 9 months from starting any biologics. 9 months is defined according to data available in clinical trials. In systemic JIA, the definition is more complex given the different aspects of the disease, including macrophage activation syndromes and interstitial lung disease. This definition was agreed upon in a meeting last year with physicians and patients and parents in Washington, D.C. Now we'll talk about untargeted treatments, including glucocorticoids. We talk about a little bit about JAK inhibitors, treatments targeting multiple pathways, and obviously talk about cytokine-targeted treatments, which are the ideal targeted treatments, obviously. Now, glucocorticoids are a mainstay of treatment. Long-term treatment should be avoided, particularly if it is done to maintain the therapeutic target that we discussed before. However, on the other hand, interstitial and tendon injection are a mainstay of treatment, and in patients with refractory disease should be possible, repeated, possibly multiple and repeated, and possibly ultrasound guided. JAKs. Now, what are JAKs? The enzymes. The enzymes are enzymes that are used by different receptor families, transducing signal for a number of growth factors and cytokines. They are highly conserved and they are non-redundant, and indeed their deficiency leads both in human and mice to very severe clinical phenotypes, being incompatible with life for some of these. Now, when applying JAK inhibitors to JIA, we should keep in mind that IL-1 and IL-18 receptor do not signal through JAK-STAT. The objective, based on what I told you before, is not to block the JAK pathway completely, but is rather to reversibly reduce the activity of one or more JAK isoform, like the dimmer in your light in your dining room. The JAK inhibitor available do inhibit several JAK isoforms with different affinity. Some of them are more selective than others, and they do inhibit a number of different families, and therefore the effect of multiple, not as targeted as a cytokine-targeted approach. There are initial case reports or small case series of the results of using, for example, tofacitinib in SJIA and adult onset disease, 2 ongoing trials with tofacitinib and baricitinib in SJIA, expected completion in April in 23, 3 years from now. There's one study with tofacitinib in polyarticular cord juvenile idiopathic arthritis who has been completed. Here are data as presented in the abstract at the EULA meeting this year for SCR response at week 44 in the randomized patients, and JADAS 27 over time in open label part 1 of the study. This is a randomized withdrawal trial. Now, to the cytokine-targeted treatments, we will speak separately polyarticular from systemic JIA, given the different involvement of different cytokine pathway. Now, this is the only recommendation that I could find regarding what to do when you fail the first TNFi, which is what we do in life. This ACR recommendation recommend to switch to a non-TNFi biologic, tocilizumab or abatacept. The level of evidence was, however, very low. And indeed, the data available for switching biologics in polyarticular JIA are really limited. Data are available only from the trials with abatacept or tocilizumab. Some data are available from real life, from registry or cohort studies. These are the data from the tocilizumab studies, where only 27 patients were previous biologic failures. And as you can see, they have a decent probability to achieve ACR 70 and 90, 50% ACR 90 at 2 years. This is the abatacept data. It's only at 4 months, so do not even try to compare. Previous anti-TNF therapy in 57 patients, response rate ACR 70, 11%, ACR 92%. It's only 4 months. These are real-life data from the UK cohort studies, a very large number of patients, most of them treated first line with TNFi. Of these TNFi treated, 25% approximately started the second DMARD, and to our surprise, to tell you the truth, more than 80% started the second TNFi. Only less than 20% received the different biologics, tocilizumab, abatacept, or rituximab. Results ACR 90, 22%, minimal disease activity 30%, no difference among the two groups. Long way to go. These are data from the Biker registry, the German registry, showing they are available only for adalimumab, showing response rate to adalimumab 6 and 12 months in biologic naive and biological switcher, patients who have failed a previous biologic. And as you can see at 12 months, there is no clear-cut difference in ACR 30, 50, 70, and 90 response rate among the two groups, suggesting that adalimumab may be a good choice. Here are the JADAS data from the same registry. What we really need, however, is comparative effectiveness trial or randomized clinical trials that do compare different approaches in patients who have failed the first biologics. This is one of the 3 studies I'm aware of in adult rheumatoid arthritis showing that rituximab and tocilizumab look better than abatacept, again, in these prospective cohort studies. We have discussed effectiveness after TNF inhibitor failure, but we need data from clinical trial. Systemic JIA, let's go back at the operational definition of refractory disease that was agreed upon last year. And this is based on the fact that systemic JIA patients have entered a new era based on the availability of IL-1 and IL-6 inhibitors. We all remember the New England Journal of Medicine of December 2012. However, if you want to look at the half-empty glass, which is what I have to do today, 40% of patients failed to achieve clinically inactive disease, and let's say 50% of patients failed to achieve glucocorticoids discontinuation. These are the failures in this study, but it should be kept in mind that these 2 trials recruited very sick patients with long-lasting disease. We all became aware in the subsequent years, and this is from Peter Nigrovich's review, that slightly modified, that there is a window of opportunity for treatment of SJIA, and the earlier you treat, the better the responses, because most probably the predominantly innate immunity-driven disease is more sensitive to IL-1 or IL-6 inhibition. There are data from real-life registry showing that this is indeed the case. This is the Biker registry again from Germany, showing that if you treat early, less than 1 year, which is really not really earlier, but relatively early, your response rate is better with both IL-1 or IL-6 inhibition. These are data from our group, the recent reanalysis, 56 patients treated with anakinra, 41 achieved clinically inactive disease off glucocorticoids at 6 months, which means 73%. Optimal cutoff for disease duration is 3 months, and your probability of response, if you're treated longer than 3 months from disease onset, your probability of response is 8-fold or lower than if you're treated in the first 3 months, suggesting that really the early window of opportunity does exist. The Mariana and Manuela went over this. They really applied to this series of patients the observation provided by Arthur et al. That high expression alleles are associated, high expression alleles in the non-coding region of the L1-RN gene are associated with poor response to anakinra in SJIA. And what they found was that in patients with SJIA, homozygosity for at least one high expression allele was functionally relevant as shown by elevated levels, and therefore this is true also for patients with a systemic inflammatory disease such as SJIA. More importantly, they found that carriage of at least one of these allele was associated with a 6-fold higher risk of non-response, and this in a multivariate approach was independent from disease duration at initiation of anakinra, suggesting that this may be something we might want to look at, particularly if you're treating patients with long disease duration. even if we treat patients with short disease duration. And if you look at the literature with both IL-1 or IL-6 inhibition, you can see that there are a percent of patients that show a significant non-response. Now, one target in SJIA is certainly IL-18. I'm not going through the body of evidence suggesting that IL-18 is important, just guide you through the data obtained in a recent clinical trial in adult onset still's disease, the equivalent of SJIA in adults, using recombinant IL-18 binding proteins. These patients were relatively long disease duration patients with a few swollen joint count, most of them treated with concomitant glucocorticoids. If we look at the 160 milligram dose, all patients went to this dose at the very end and looked at the efficacy analysis, we found that only 40% of the patients achieved the primary outcome. The primary outcome in this study was improvement of joint count by more than 20%, far from clinical inactive disease, and reduction in CRP and of ferritin. Now, the reason why interleukin 18 may not be involved in directly in the chronic inflammatory process is because a vast body of evidence points to IL-18 as being a cofactor for the overproduction of interferon gamma that leads directly to the concept that IL-18 may be involved in predisposing to MAS. And this is indeed the case. This is a study from Alexis Grom's group showing that patients with JIA and the history of MAS, even without MAS, have higher level of IL-18 compared to patients without a history of MAS. And there is one case report, again from Alexis group, of one patient with long disease duration, interstitial lung disease, and recurrent severe MAS, who was treated with IL-18 binding protein, recombinant IL-18 binding protein. He showed a stabilization of disease, reduced MAS severity, and was able to taper steroids significantly. Now, another issue in SJIA is interstitial lung disease and particularly the inflammatory PAP-like disease that is present in this patient associated with some weird digital clubbing as well as some non-really typical rash. These are the three key papers that I suggest that all of you read. There is one case report suggesting, showing or describing success of treatment using ruxolitinib. There are, however, mounting evidence that lung disease is indeed associated with MAS. Most patients with interstitial lung disease have a history of MAS. Higher ferritin level do precede the onset of MAS, and there are indeed observations suggesting that showing higher circulating levels of interleukin 18. And again, we point to interferon gamma, and the data point to interferon gamma. Data from lung biopsies from patients with interstitial lung disease and SJIA showed predominant CD4 positive T helper infiltrate, high IL-18 in bronchoalveolar lavage, and overexpression of interferon gamma induced genes in lung biopsy. And interestingly, there is a model of inflammatory PAP-like disease caused by Tbet overexpression in T cells. CD4 positive T cells are overrepresented in the lung of these mice. They express high amount of interferon gamma. There are high levels of inflammatory cytokines in BAL, and the overexpression of M1 macrophage genes in the lung, including our favorite interferon gamma and CXL9. These mice do die of this disease. And we go back to the concept of interferon gamma being a downstream mediator of the vicious circles once you have passed the threshold, independently how you got there. In murine models, interferon gamma blockade has shown benefit when tested in model of primary and secondary HLH. The trial with emapalumab in children with primary HLH saw a significant efficacy data that led to the approval from the FDA for primary HLH, and there is a vast body of evidence supporting the therapeutic neutralization of interferon gamma in MAS during SJIA. There is an open label single arm multi-center study which has been concluded recently. Data are available for the first 9 patients enrolled in the study. Is being presented at this meeting as a short communication. Suffices to say is that 9 out of 9 patients achieved complete response at week 8, 6 at week 4. There was marked glucocorticoid tapering during emapalumab treatment up to week 8. In summary, we have talked about untargeted treatments. We have talked about JAKs and the initial data in JIA and particular core JIA. And we talked about cytokine targeted treatment in poly and in systemic JIA. I'd like to thank for your attention. I wish we can see each other face to face. This is a nice, at least I will share with you a nice sunset from the Children's Hospital in Rome. I'm available for any question you may want to ask. Thank you again.
Happy morning. I bring warm greetings from CMC Vellore in India. I want to thank the press organizers, scientific committee for inviting me to deliver a talk on how do I manage a refractory JA in a developing country perspective. There's no conflict of interest. So the outline of my talk: what are the challenges in a developing country when we treat a child with refractory JA, and what is a refractory JA, and how do we manage a child with refractory JA in a developing country. A small introduction about me. I am Dr. Satish Kumar. I'm a consultant pediatric rheumatologist from Hospital of Sick Children. You all know where I am from now. So this is India. In India, the southern part of India is my province called Tamil Nadu, which has got about 6.6 crores population. And my hospital is called Christian Medical College, Vellore. Our town has got a population of 4.8 lakhs. Okay, so I was trained in pediatric rheumatology in Hospital for Sick Children from 2006 till 2009. After finishing my training, I came back to India and we started our clinic, pediatric rheumatology clinic. When I came back, I see a lot of children who has got with arthritis. This is the first photograph is a child with systemic JA was given steroids for almost 2 to 3 years. You can see the short stature. You can see the lot of joint deformities. This is a children with polyarticular JA who has got a lot of buttonhead deformity, swan neck deformity, wrist drop, bilateral knee contractures. This is an 18 years old boy who has got enthesitis lateral arthritis because of treatment which was not appropriate. He developed the typical AS patients, and we also see a flexion deformity. So what is the difference what we see from the West type of presentation? So after starting my clinic in the last 11 years, we have almost 800 children with juvenile idiopathic arthritis. This is the breakup of this. If you see here, oligoarticular JA is only 12%, which is contrast what we see in the West, which you see a lot of oligoarticular JA. So our main group of patients are systemic JA, more than about 35%, followed by polyarticular RF negative, and enthesitis lateral arthritis form a major group compared to the Western literature. So what are the various recommendations for management of JA available in the literature? From 2011, we have a recommendation from ACR, then 2013 for systemic JA again from ACR, and we have a share initiative for uveitis management associated with JA, and 2019 again ACR has given a guidelines for therapeutic approaches for non-systemic polyarticular JA, sacroiliitis and enthesitis lateral arthritis. Can we follow all the same guidelines in India? Is it applicable to India, where I practice? So refractory JA definition. So in the clinical practice, when you see a child with JA, somebody has got active disease in spite of methotrexate, plus or minus steroids and NSAIDs, who has got high disease activity and poor prognostic factors, which is well mentioned. So what are the challenges in our country? So we face two main challenges in our country. One is the availability of the biologics and the affordability of the biologics, which is a cornerstone in the management of refractory JA now. So what is about regarding the availability? So we are lucky in India. So we have almost all the biological agents are available in India, especially TNF-alpha blockers. We have etanercept, we have infliximab, we have even golimumab and adalimumab, and we also have secukinumab and rituximab. Biosimilars, we have etanercept biosimilars, infliximab biosimilars. Adalimumab, we don't have the original innovator in our country. We have a lot of biosimilars adalimumab, and rituximab, we have the biosimilars. Fortunate or unfortunate, we don't have any one of the IL-1 blockers in our country, especially anakinra, canakinumab or rilnocept was not available in India. So the main issue is affordability. So here is a table to show how much it costs in euros about each drug. Especially methotrexate is less than €1, even if you use injection. Etanercept, these are the innovators' cost. Okay, if you look into the cost, if you compare to the euros, it is very, very cheap. But still, what is the problem in India? In India, 80 to 90% of our patients pay out-of-pocket expense. So they don't have an insurance coverage. So most of the patients pay from their own. So the insurance coverage is less than 10%, especially in the urban area. Rural area, the coverage is still more or less. And our government gives insurance to mainly to their employees or for the other people who has got low socioeconomic status, that too mainly for life-saving drugs and procedures like cardiac surgery or emergency surgeries, not for the chronic diseases were included in the national coverage. And you also know that per capita income for an average Indian is 11,254 rupees a month, which is equal to 130 euros. So that is a big affordability issue for biological agents due to lack of insurance coverage, and the cost of the drug and per capita income is very low. So how do I manage a child with juvenile idiopathic arthritis? Especially I divided into polyarticular course and with systemic JIA. Polyarticular course, when they come, we always start them on steroids or NSAIDs. Steroids depending on how severe the arthritis is at the time of presentation. And as a bridge therapy, we start them on either oral or subcutaneous methotrexate. We start with full dose, 15 mg per meter square per week, and we follow them. So if they show improvement, that is very good. So methotrexate is working. We observe them and we continue the methotrexate. And if the disease flares while the patient's on methotrexate, or if the child has got inadequate response to methotrexate, we consider adding the second DMR, either sulfasalazine or leflunomide. If they are not affording a biologic, either because of their income or due to lack of insurance, and see if they improve, we continue to methotrexate and sulfasalazine plus or minus leflunomide. If there is no response after adding sulfasalazine or leflunomide, if there is no response, we consider giving TNF-alpha antagonist, and that too, remember that the patients are paying from their pocket. We cannot keep on giving TNF-alpha antagonist. We give it for 6 months and try to taper and stop. If there is improvement, we try to maintain the conventional DMRs, and if there is inadequate response to TNF blockers, we switch to another TNF blocker or we switch to the IL-6 blocker. In between, we'll give a short course of bridging steroids for a child with polyarticular course. Is it evidence-based? Do we have any evidence to give 2 or triple conventional DMRs in a child with polyarticular JA? There is a multinational randomized controlled trial on polyarticular course JRA from Hospital for Sick Children in 2005. So they did a double dummy blinded fashion. They have 94 children. They gave methotrexate for leflunomide for one group, and they gave methotrexate plus placebo for another group. The assessment was ACR 30 response, and the percentage improvement index was measured every 4 weeks. At 16 weeks, they want to see the primary outcome. They also have the open blinded extension for the next 32 weeks for all the children who were in the trial. So what were the results? So initial study, you see that ACR 30 response was almost 90% of the children with methotrexate and 70% in leflunomide group, which was statistically significant. The mean time to the ACR 30 response was not big difference in leflunomide or methotrexate group. And you can see the percentage improvement index. That is also leflunomide did little better than the methotrexate. And the extension study also, they found same thing. Whether you give methotrexate alone or methotrexate plus leflunomide, they both have very good improvement. So what do they conclude? In polyarticular juvenile rheumatoid arthritis, methotrexate and leflunomide both result in a high clinical improvement, but the rate was slightly greater for methotrexate. So coming to systemic onset JA, so here again we divide them into who has got predominant arthritis manifestation. So if they have predominant arthritis manifestation, we treat like polyarticular course JA. So we give them methotrexate. If there is no response, we go to TNF blocker. If they have fever and other systemic features, we try them with NSAIDs for 1 to 2 weeks. If there is no improvement, we add on systemic steroids for next 2 to 4 weeks. If there is improvement, we try to taper the systemic steroids and try to stop because they are monocyclic systemic JA. If they don't able to taper, we consider changing our steroid sparing drug. If there is inadequate response to corticosteroids, we add on methotrexate as a steroid sparing agent, cyclosporine, or if they are affordable, we give tocilizumab or thalidomide. So based on the different clinical scenarios, we try to use these drugs. So IL-1 is not available in our country, as I said earlier, so there is no chance of using IL-1 for systemic JA. So how do you manage? So is there any evidence for cyclosporine? So this is a recent paper in Indian Journal of Pediatrics. The cyclosporine in resistant systemic arthritis is a cheaper alternative to biologics. So here they have almost 15 children were followed. They have the criteria to start on cyclosporine, repeated flash on stopping, or attempting to taper steroids in spite of being on methotrexate. So somebody is on steroids on methotrexate, 15 children were included, and 13 responded to cyclosporine. So what do they see? They see very good response, deference of fever in almost within early 2 weeks. Joint improvement did take a little long time, which was not, only 5 children were able to control the joint. And there is good reduction of ESR and CRP and the hemoglobin increase. And the very important thing is the decrement of the dose of steroid by 50% in almost in all the children were able to reduce the dose of steroids. So what they concluded, cyclosporine was effective in almost 75% frequently relapsing steroid dependent systemic JA to achieve and maintain remission. The cost, when you look into the cost compared to the tocilizumab, it is almost 1/10 of the cost of biological agents. Thalidomide. So thalidomide in systemic JA is not new. We have a lot of case reports from Journal of Pediatrics from 2002. 2 children did very well on thalidomide, and we also have from India from 2012 again 3 children with thalidomide. Then again efficacy of thalidomide systemic JA. This is from Mexico again in 3 children. These are very few case reports, and there is one little bigger one. This is an abstract presented in 2017 Pediatric Rheumatology Symposium from our group, not from India, from Delhi, Dr. Sujata Swani's group. What they showed retrospectively 48 children with systemic onset JA, and response in the systemic features 94%, very good response in systemic features. Articular response is about 50%, and no response was seen in to thalidomide was seen in 6% of the children who are treated with thalidomide. So when they look into the details of that, you can see here median age at thalidomide commencement was 7 years. The mean dose of oral steroids before starting thalidomide was 0.5 milligram per kilogram per day. But after 6 months of thalidomide, they are able to come down to reduce the steroid dose to 0.01 milligram. And steroids were stopped after thalidomide in almost 60% of the children. And again, very good response to systemic features in a month, and for articular disease in 3.5 months. So how do you do biologicals? If the patient is affordable and if the patient has got insurance, we try to follow the American and the European guidelines. We try to start biologicals earlier. So based on the economical status, whether it's a self-paid or insurance coverage, patient's preference and doctor's preference, what do you want to give? Either etanercept or adalimumab. Recommendations, we follow the recommendations as per the advice. So selection of the appropriate children is very crucial in our setting. We give it for usually for 6 months and try to taper and see the response. If you're able to taper, that's very good. If the disease, remember that we'll continue the conventional DMRs every time we give the biological agents. And sometimes we use biological agents if the patient is not very affordable. We treat during the intermittent, during the flare for 3 to 6 months of biologicals and put the disease under the control, and we try to use the conventional DMRs. So what's the take-home message? So managing refractory JIA is challenging in a developing country like India. Our main problem is affordability more than availability. With this, all these challenges, we have more opportunities to use the other drugs. There is no big randomized evidence for the cheaper or the older drugs like thalidomide, cyclosporine, leflunomide. Lack of evidence does not mean those drugs does not work. So with this, I want to stop. Thank all of you for your patient listening. This is one of my patients, systemic JA, who was on thalidomide, who cannot afford the biological agents, and with a happy ending to say that this is in Press 2018 in Lisbon, Portugal, with my mentor, Dr. Ron Laxer, and with my close friend, Dr. Ron. I will stop it here. Thank you very much for patient listening. Thank you.